as we appear to be moving into a new phase, and by the way, a new phase where we're still expecting another variant to arrive, right? BA2, which went through China and now is moving its way through Europe. How, from a public health policy perspective, should we be thinking about where we are, considering that most Americans kind of are over it, right? Their behavior is reverting to the norm.
Yeah, well, I mean, and there's this, saying now that we're done with COVID, but COVID's not done with us. And for many, COVID wasn't a one and done. Many people still have long COVID. Many people are very vulnerable. I wrote about other epidemics that we're ignoring. But for me, I think what has been most optimistic in a great way is that the majority of people that are at highest risk have received a booster, right? So if you look at, Pfizer looking to continue to boost a fourth dose in those over 65, we have 48 million Americans that have already received a booster, and 2/3 of those over age 65 have received their booster. So they're protected. So even though the BA2 variant is now on the scene, and we'll continue to see variants. I mean, they continue to replace each other. This virus is going to continue to look for a vulnerable host. I think knowing that we have protection in those over 65 is most important. You just heard the CDC director refer to some data. I was just looking at some Finnish data that showed those over 70 who received 3 shots, 1 booster, have 96% effectiveness against hospitalization and severe illness. So the debate is, what are we solving for with the 4th dose? Are we trying to prevent mild disease, or are we trying to prevent hospitalizations? And I think it's the latter. So I'm looking forward to the debate and the advisory panels at the FDA on both the 4th dose for Moderna and Pfizer, because I think we need to understand we're not going to be in a situation where there is no cases. That's just not possible. We're entering an era, as you said, Julie, where this is now becoming endemic.
Meghan, I'm so glad you brought that up, because I think that that's been the argument and the discussion, especially when you talk to health experts about what are we solving for? What's the goal of the vaccines and of these boosters? And now we also have in the backdrop treatments, especially Pfizer's, to help with that avoidance of hospitalization. So I wonder, in context of that, are we getting to a point where maybe even for those 65 and older, we don't necessarily need that 4th dose, and we could see maybe a restriction on who gets these additional doses?
I think that's right. I think you will see a restriction because of the data I just cited. They're holding up. They're getting great protection. Even as BA2 starts to overtake Omicron, you're not really seeing an uptick in hospitalizations yet. And I also want to remind everyone, 65% of the global population has only received 1 dose. So while we debate a 4th dose in the United States and we continue to be concerned about variants, we have people around the world who are just as vulnerable and just as risky to us, as long as there are variants. They deserve to have their 2nd dose and their booster. In fact, 19% of the continent of Africa has only received 1 shot. So we shouldn't be surprised that we continue to see variants, but this remains a global pandemic. And so there is a luxury to talk about 4 shots, but there's an absolute dire need to make sure many receive their 1st and 2nd shot.
On that point, Meghan, I want to touch on the statistics that you just cited with the global vaccinations. It seems like that has been one of the issues facing the discussion of boosters, and especially on supply, whether or not that supply will reach there. We know there's been a local investment as well in production, but none of that seems to be coming to fruition until later this year. So on that point, should we be rerouting, booster doses to other parts of the world then?
No, I think, well, we're throwing doses out here in the United States. I think what we need to reroute is last mile logistics support and ability to help, with cold chain, or even look at other products like J&J that don't require cold chain. I think what we've kind of failed in our effort to vaccinate the world is that getting shots in arm is really the challenge, and that the resources supply to do that and the staff is what held up and has been shown to be a bottleneck.
You mentioned J&J, Meg. Amidst all this focus on boosters from Moderna and Pfizer, how's the uptake on the J&J shot been?
Not well. I think some of the early negative press on J&J basically just said, let's move on from this. And then recently in the last week, we're seeing that the efficacy did in fact hold up. So I think what we've learned in this pandemic is it evolves. You get new data, you turn over new cards, and you see what the data shows you, and then you make decisions. We're in a pandemic, so we did the best we could. But I think sometimes what you see is in the fog of what goes on with the lack of information and good data, sometimes politics fills the gap and bad communication. We even have down here in Florida that we might be moving towards not ever recommending vaccines in healthy children. So I think we need to do a better job, and we've discussed this on this show for the last 2 years, to make sure we as a public health community really get our act together on the communication front, because there's always someone that will fill the gap. And so quickly we wipe away what maybe could have been an alternative or better option. And I've certainly always thought we should consider J&J because they do have the logistic benefit, assuming safety and efficacy are there, obviously.
Meg, I want to turn away from the pandemic for just a moment, because you wrote a really interesting op-ed recently with some eye-popping numbers about what's happening sort of in the background of the pandemic, the other health issues that people are having, particularly mental health. You cite data that emergency department visits for suicide attempts among teenage girls were up more than 50% from the start of the pandemic. This is alarming stuff. And so how do you think we transition out and address some of these acute other health crises?
Yeah, and I was just looking at others. 13% of adults report abusing substances to deal with the pandemic. We have a rate of obesity in children that we've not seen in decades. Obesity among young kids is up 22%. Said another way, 1 out of every 6 kids are obese. We have to learn that COVID is not our only epidemic to deal with. We're a $4 trillion healthcare system. We have to be able to deal with multiple epidemics at once. It's unfortunate many of the things that were put in Build Back Better would have been there to support access and other, opportunities to address these epidemics. I think we're looking at things around the periphery, such as telehealth, making sure in some states that we have Medicaid coverage. A lot of this comes down to access. During the pandemic, many people put off medical procedures. They were either afraid, they didn't have access to care, or they were hit with financial constraints. So we're in a big dig out for a while as you see all of these patients start to come back to get screened, to book surgery, to get a primary care visit. We all know people that have put these things off, and it's really, really hit the underserved communities very, very hard. So my answer to you is it's not just one epidemic anymore. I think I wrote this is, not epidemic Shark Tank. There shouldn't be one winner. We have to figure out how to address all of these. They're also interrelated, by the way. For those that have long COVID, also have many, of the symptoms that you see in other epidemics, whether it's mental illness, cardiac problems, respiratory problems. So we're now seeing, a big interrelated system where there's multiple things to address. It's going to be hard times for the next few years, for sure.
Definitely some learnings out of that, and especially with long COVID as well, understanding that. I wonder, though, speaking of learnings, you mentioned the J&J as well, bad press earlier, bad issues earlier, getting in the way. Whose responsibility is it right now to sort of encourage the uptake of vaccines? We know Novavax is pending for one, and there's been discussion about the waning immunity, quick waning immunity provided by the mRNA vaccine. So should we be having a different conversation about this going forward?
I just think we need radical transparency, good or bad. If you get some bad data, explain it, but don't discount or wipe away an option. We're so quick to kind of jump to a conclusion when we see an early signal. It's very common when you go from phase 3 into the general population, what we call, post-marketing surveillance in phase 4, that you're going to see an increase in adverse events. And when we do, we need to really characterize those as super rare or super common and label the drugs or the vaccines around it versus saying, listen, we have an alternative. Maybe in the US we had an alternative, but the rest of the world then says, wait a minute, am I getting a secondary or unsafe product? And I'm unsure that was true. So I've always called for radical transparency and I think more collaboration among the public health community. You saw Canada today approve Moderna's vaccine. We're submitting for emergency use authorization in all patients. We have debates on, what we should do for, pediatric patients under 5. Pfizer is applying for a 4th dose in people over 65. So, you can understand why the general population is confused and a little bit fatigued.
Yes, we certainly can. Meg, it's always great to catch up with you. Thank you so much. Meghan Fitzgerald, PE investor, author of Ascending Davos, and healthcare policy professor at Columbia University, and our Anjali Kamlani as well. Thanks so much.